go further, this study, this says that survival is equal if, particularly in low-grade tumors. And based on this study, the EU guidelines recommendations are that nephron sparing surgery should be the primary treatment option in the patient with low-risk upper tract urothelial cancer. Now you have diagnosed this patient. This is a low-grade TCC, small tumor, and now you are going to counsel this patient for endoscopic fulguration. There are a couple of things that you need to be aware of. There is a risk of perforation of the renal pelvis or ureter. When you're doing a lasering, it's important to know about this, that there is a very, very high risk of perforation. I've done a couple of perforations myself, because when you are a big tumor, you don't know how much deep you're going in. Uterus stricture is again very common, and particularly this was more common when I used to do the diathermy fulguration in the ureter. But now with the laser, still depends how big is the tumor. And then you need to tell him that you need to do a second ureteroscopy in 6 to 8 weeks time. This is what the guidance is, but in my practice, I usually give them around 3 months time. And this patient will need a long-term surveillance. You will need the patient to bring back again and again in 6 to 9 monthly. There is a risk of disease progression. Obviously, we have seen that the cancer-specific survival is not so good as nephrectomy. And there is septicemia and the risk of bleeding. Procedure is usually done under general anesthesia. We give antibiotic at induction, lithotomy position, we do retrograde pyelogram, and we use an access sheath. In ureteric tumors, remember, usually the size recommendation is around 2 centimeters. I've done bigger than 2 centimeters as well, but then the risk of complication increases. You have to be very good to make sure that you do it properly. There's a risk of perforation, risk of stricture, bleeding, everything increases.